All right, good afternoon, everyone, and welcome to our Wu University CE event. This presentation will be over an opioid update with Dr. Eissa Hanna. I will be your host tonight. My name is Dr. Ariel Sorenzi. So I'd like to introduce our speaker, Dr. Eissa Hanna. He's probably doesn't need an introduction because he's had some pretty epic presentations on here before. But just in case you haven't seen him yet, he is currently at a private practice in Las Vegas. And before that, he was at University of Washington as a professor at the School of Medicine and has trained over 150 residents and fellows, and had various academic and clinical roles. And that's the last presentation you did. That's where we got to see all of those really cool traumatic injuries that you helped manage, that was an awesome presentation. So I'm going to go ahead and have you take it away from here, and we really look forward to hearing you.
All right. So I don't have any financial disclosures to make. And all financial relationships have been mitigated. So the big question really is there a role for opiates in eye care? I believe there is. And it's going to be up to each individual one of you guys to kind of decide what that is for you and in your practice and for your patients. The government, they're tight on this stuff, but they didn't take away your autonomy for this. And you as care providers, must make these decisions. So am I an expert on opiates? No, I didn't do any research on opiates. I didn't, invent them. I don't, but I have used them for about 15 years. And, you might wonder, like, why, listen to this guy? Well, I'll give you a little bit of my background and my diverse background, and I'll share with you throughout this presentation my experiences so that you can, hopefully learn something and maybe utilize what I've learned in the past as well. So before moving to Las Vegas, I had a clinic across the street from this hospital. This is Harborview Medical Center. It's part of the University of Washington medical system. And what's unique about this place is that it's a level 1 trauma center. And it's also a community hospital, which means we see everything, uninsured to billionaires, from homeless to, the worst. The people that want the highest level of acuity, they come here. And not just from the state of Washington, but we were responsible for 5 different states. And in my clinical practice, I was seeing patients, as far as Alaska to the Cayman Islands, to some of the Pacific Islands, to Arizona. People were flying in for, specialty care and device. And speaking of my clinical roles, I had 3 days of, let's say, clinical work and then 2 days of surgical work. And half of my clinical work was, outpatient, similar to yours. We saw similar stuff and, maybe some different things as well. And then half of my days were spent with inpatient ophthalmology. Inpatient ophthalmology is a little different than outpatient ophthalmology in the sense that you're in the hospital because you got something really, 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 really bad with your eyes or your orbit, your face, and you need eye care for that specifically. Or let's say you have a multi-system issue because of a motor vehicle accident, bear attack, or whatever it's under the sun. You're in the hospital, but you got eye problem. We took care of it. It wasn't all clinical and surgical work. A lot of that, being at the university, you train people, you go through residents, you go through fellows, And when you're there, they make you do other things, and one of my other roles was the director of ophthalmic trauma services. I had to sit on various panels to make multidisciplinary kind of decisions across the board with other panelists. I was the chief of comprehensive anterior segment services. So I've got a lot I've seen a lot in terms of eyeball pathology, and I'm taking care of a lot of eyes. So when we go through this course, you're going to get some of my perspective on this. And I'm hoping that you can apply the way that I've thought through some of these cases to some of the things that you're going to see. So in terms of the course objectives, we are going to, talk about opioids. That's one of the things that we're here to do. We're going to discuss the opioid epidemic. We're going to talk about some ophthalmic and periocular pain management and your role as a provider and your responsibility in all this. All right. So I always like to start off with a pre-test to kind of test your basic knowledge of some of this stuff. And, it's not looking, you don't have to have all the answers, and we'll have some of the answers toward the end. Mind you, some of my photos are graphic, but they do make the point, and they're here for educational purposes. These are all patients that I've taken care of. And one of the things is I respect them very, very highly for what they've been through and what they've gone through and their willingness to share their experiences. So I ask you the same. All right, our first case and in our pre-test is this gentleman. I'll let you take a look and just kind of try to see or notice, try to make what are you looking at here, first of all? Well, I'll tell you, this is came in one Monday morning. I got a page by the maxillofacial chief of service to rush up to the OR. And I was like, okay, put my coffee down the side, went in, and I was introduced to this gentleman. So what happened to him? He was driving unrestrained, was ejected from his car and flew through the window and hit a pole. And so if you could see, his face is split in half. And this is where his eye. Can you guys see my pointer? Ariel, are you there? Can you see my pointer?
Yes, we can see it.
Oh, okay, cool. So this is his eye. His orbit is completely fractured in half. This is his nose. It should be up over here. So it is an absence of orbit. There's dirt and vomit. This looks like to be his tongue down here. This is his lower lip and the side of his face. All right. So first question posed to you, good people. Opiates are necessary to treat this patient's pain acutely and up to 1 year after injury. Think about it. True or false? Very simple question. Next question. Gabapentin will work well to control this patient's nerve pain. True or false? All right. This less memorable. We see these kind of things all the time. And this is a trauma case. This is a gentleman who was working on his car and the fan blade somehow made its way up across his face. You can see that he's got a frontal fracture. He's got an open globe injury and a lateral orbital fracture. Oh, total hyphema and the eyes a little bit bulgy. All right, question. Most patients with similar injuries require an average of 2 weeks of opiate treatment. True or false? All right. This is also a little less memorable because we see stuff like this all the time. I believe this was it was a corneal laceration with a rupture of the lens. You could see that the lens capsule is still intact superiorly, but is completely blown up down here. Question: most patients with similar injuries require an average of 2 weeks of opiate treatment. True or false? Well, this gentleman, this was another Monday morning. Actually, I think this one started for me very, very early Monday morning, maybe even Sunday. I first was in touch with the residents about this one. So this gentleman, he was a Chinese national who was detained by the Border Patrol on the Canada-US border, and he was suffering an acute psychotic disorder. And when he was in detention, auto-enucleated his eyes. So if you've never heard about this, what these people do is they reach in and then they pluck their eyes out. So when he presented to our institution, he looked like this. The residents called me. They were like freaked out. What are we going to do? What are we going to do? What are we going to do? I told them, okay, well, just go in there and push him back in. And they're like, really? I'm like, yeah, exactly. Just do that. And they did that. And then he was left unattended somehow, and then did it again. And this is the photo of second attempt. Now the question is, opiates are indicated in the acute management of this patient. True or false? All right. Now this is something maybe that, well, actually more likely you're going to see this than any of the other cases. What do we see? Well, a highly injected eyeball, a cloudy cornea, and 2 infiltrates. We can invent a clinical scenario here. Contact lens wearer, felt like they had a scratchy eye and presents. Question: opiates are indicated in acute management of this patient. True or false? All right. Now that you've had your pre-test, I expect 100% at the end of this discussion with these true and false questions. You guys are going to rock it, all right? Let's begin our talk. Part 1, opiates. So opiates, they have been around for, people aren't exactly even sure how long. The estimate's about 7,000 years. There's Neolithic burial sites that have found, they've dug them up and they've found evidence of the poppy plants there. The ancient Greeks have written about it, and the Sumerians called it the plant of joy. And most of us, growing up in the States, through some form of pop culture, have seen, in various media outlets, images similar to this of the opium dens, in the 1800s, people going in there smoking opium. I've even had some friends who've told me about their great grandparents, smoking opium. It's was kind of part of their culture. It wasn't until about 1804 that it was that morphine, the prototype, was isolated by this chemist, Friedrich. I'm unable to pronounce his last name correctly, so I won't. But he's credited for being the first one to isolate it. And this is what we're talking about, morphine. Plato would call this the archetype, and it is the archetype or prototype molecule for all the opiates, from codeine to oxycodone to fentanyl. If you notice, there's these functional groups here, these OHs, these hydroxy groups on here. And what that does, that allows for the structure to be modified. And when you modify it, it'll either increase or decrease binding capacity, bioavailability, all that stuff. And that's how we get all these different drugs. So when we talk about opiates, we have to, start with some definitions here. And I think the biggest one is defining the schedule of controlled substances. So what the heck is a schedule? Well, there's 5 of them. Schedule 1 being heroin, ecstasy, weed, drugs like that don't have any medical use, or there's no safety, and there's not a good safety profile for these things. They're highly addictive. They have a very, very, very high potential for abuse. So that would be like Schedule 1 drugs. Schedule 5 on the opposite end of the spectrum are things like cough syrup with codeine in them. And, there's certain requirements of how many milligrams per, milliliter, et cetera. But the point being is they have a very, very, very low potential for abuse. So like there are people that, go out and drink like antifreeze, right? So sure, maybe you can get like 10 bottles of Robitussin AC with codeine in it and drink 10 of those, but it's not practical. And these are still prescription required. The opiates that we're going to focus on and are part of the Schedule 2. So there's a huge list here, and and if you're paying attention and you kind of zoom in, you'll see there's other drugs here that aren't opiates, and that's true. Like benzodiazepines are Schedule 2, but there's a large list of Schedule 2 drugs. And Schedule 2, they do have a potential for abuse, and as evidenced by our society, have been abused. And we're going to review some of the common ones. So we're fortunate that there's only really 9 of the ones that have, are most commonly prescribed, and I'm going to go through those. I call them the infamous 9, and I'm going to review those with you. All right, so codeine is found in formulations that are Schedule 2, 3, 4, and 5. It does have street names, Captain Cody, Cody, or Schoolboy. And interestingly, people are smart enough to be dangerous. And what some folks do, there's another medication called glutathione, which is an enzyme inducer, and they mix it with codeine. And what that does, it increases the conversion of codeine to morphine, so you get a little bit more high. And when you do that, it's called a doors and fours. I've heard that before. Over the counter, or not over the counter, but prescription forms of codeine is the Robitussin AC, and that's the Schedule 5. And then Tylenol with codeine, that's the Schedule 2. People swallow this stuff. And that's how the routes of administration are. Methadone has one sole medical purpose, and that's really to get people off of heroin or morphine or opiate addiction. But this is also abused. And later on in the talk, I'll show you a chart and we'll revisit that idea. But street names include fizzies, amiodarone or ammies. If you mix it with ecstasy, you might hear the term chocolate chip cookies. Brand names are methadose, Dolphine, and people typically inject or swallow this. Over the past couple years, you're finding more of the destitute population actually smoking pills or just crushing this stuff and smoking it. It's really, really horrible smell. It smells like burnt peanut butter and plastic, but people are desperate. Oxycodone, Schedule 2, 3, and 4. Street names go by Hillbilly and Perks. This is probably the most common one that I've prescribed, like on an outpatient basis, and sometimes inpatient also. And even myself with the residents, they say, "Hey, Dr. Hanna, what do you want to give them?" I'll tell them, give them a couple perks. Send them off with a couple perks. So it's a very common term. The prescription names or brand names is OxyContin and Percocet. And again, these are some people, the abusers will take these, they will crush it up, inject it, swallow it, snort it, and even suppository. Hydrocodone is another one that you may be familiar with or have heard. It's a Schedule 2 drug. It has formulations Schedule 3 and 4. And these go by Vikes or Watson 387. So I was kind of curious. I was like, how would you get like a Watson 387 out of this? And so I did some Googling and I found a song on Spotify. It's called Watson 387. That didn't answer my question. I'm like, why do they call it Watson 387? Anybody got any ideas? Any thoughts? Well, I did find it. So the pill itself has says Watson 387. I tried to Google and tried to look a little bit harder and deeper, and as why do they put the Watson 387 on the pill? I no clue, couldn't find out, but I don't know, satisfied my curiosity enough for that. It looks like we have a question.
Yeah, so the question was, is methadone also used for long-term chronic pain?
I'll tell you, I'm not a pain doctor, so I don't know. I just do know that what we do use it for, and the patients that I've had that are on it, it's for getting people off of long-term morphine or opiate usage. It does have some analgesic properties, but as you'll see like later in the slides, it's like a partial agonist, or it's like an agonist, but it's missing some of the euphoric symptoms and some other things. So it's possible, but that's really, really what it's like, at least my understanding, it's used for getting people off from being hooked. So like, even I'm pretty sure even in Las Vegas, they've got what's termed these methadone clinics. We had them in Seattle for sure. And the lines were very, very long. And it was most of the people that I would see, they just looked pretty kind of like the junkie group. So
Okay.
Any
Cool.
other questions that you want?
That's all we have for now.
Oh, okay.
Thank you.
Let's see. I guess we were talking about, so Vicodin, I think that's so Percocet and Vicodin are the two opiates that I've tried. The Percocet was, for me, I had a wisdom tooth extraction, and then it got infected. Or no, that was my root canal. I had a root canal done and it got infected. I was miserable. And the dentist gave me that one. I took one pill, it gave me the itchies all over, and then it just knocked me out and I fell asleep. So I guess it did its job. But Vicodin is the other one I tried, and it really didn't do anything other than make me feel like I had like itching underneath my fingernails. It was weird. So, but Vicodin is also very, very common. People inject, swallow, snort, suppository. And latest trend is smoking pills, smoking crushing pills. All right, so how do opiates work? Well, there are opioid receptors all over the brain, midbrain, spinal cord, skin, and GI tract. And they're G-coupled protein receptors. Their subtypes are mu's, kappas, and deltas. So, let's say morphine or the opiate itself attaches to these receptors and gives the desired effects. So if you look here, and it's worthwhile trying to spend a little time on this slide. So the mu receptors are pretty much responsible for a lot of the effects of morphine. There's actually a mu delta receptor hybrid that does a lot of this. But let's pay attention to a few things. So you're going to get analgesia from all of the receptor types, but the euphoria and the reward and incentive mechanisms are coming from that. Also, why opiates are very, very dangerous, especially in high doses, is the respiratory depression in the midbrain, and you've got these receptors, and you got the morphine bind there. People stop breathing, and that's how they die. And then, if you also notice, you've got the physical dependence. There's a lot of physical and psychological effects induced by these drugs, just based on the nature of where these receptors are. Now, I'm going to throw a question out there, and I don't know if we have a way or if we have a brave soul to kind of try to answer it. But so narcotics, right? These opiates, what do they do to your pupils? Where's there you are.
Yeah, if you guys want to answer any questions, feel free to add them into the chat.
Or hey, you're my co-host, my radio co-host here. No pressure.
I think they dilate, right?
No, in fact, it's the opposite. So opiates,
really?
Yeah, opiates constrict. So opiates
okay.
constrict the pupils. Cocaine dilates.
Okay.
Yeah. So here's another question, and I'm not looking for, but oh, look at that. There's
well, everybody else got it right.
Yeah, bravo to everybody. But so yeah, they constrict the pupils. So there's receptors in the hypothalamus, because that's where and there's also receptors in the trigeminal nerve for these opiates. And that's kind of like the mechanism, of how it'll affect the pupils. Because in the hypothalamus itself, that's where all of the sympathetic nervous system begins. And if you're blocking that, right, if you're inhibiting that, and because if you recall, sympathetic, fight and flight, dilated pupil, right? So if you're inhibiting that, you're going to constrict. So you've got all parasympathetic working at that point. All right, so I like this slide a lot, actually. This is a study in one of the journals, pharmacology journals, done by Peronis and Woods, where what we're demonstrating here is tolerance. So bear with me. I'm going to spend a little bit of time kind of trying to look and understand at this. So if you look at this axis here, you'll see maximum possible effect of the drug. All right. And here on this axis, what we're doing is we're giving monkeys more drug, and we're testing to see what's the maximum possible effect. Now, so these are Reyes monkeys, and they're sticking their tail in the hot water, and they're looking at latency and withdrawal. So, like, you know, if you stick a monkey's tail in hot water, you know, and you're not blocking any of the pain receptors, they're going to pull it out real quickly. But if you're blocking the pain receptors, you're going to pull it out a little bit slower, and et cetera, et cetera. So you'd expect at higher doses of morphine, you know, that you're going to be a little bit slower in pulling it out. The other thing, they were also looking at other autonomic functions like respiratory rates and whatnot to try to kind of judge pain. Now, at baseline, so the green line here, so is a monkey similar to me who's never been on opiates, and you stick their tail in the water without any morphine, they're going to just like, boom, get a full effect. You know, if they're naive to morphine and you give them 1 milligram, you know, you're going to get the full maximum effect. And as you can see, the more morphine you get more maximum effect from the drug. Now, the orange line represents monkeys who've been given 3.2 milligrams per kg per day over a 4-week period of morphine. So every day they're giving them this morphine. And you could see that as you increase in dose from 3.2 to even 6, right? So the more morphine they're chronically on, the less effective it is. So this was like the first evidence that shows tolerance to the drug. And this is kind of important in a way, if you think about it, right? So the more that you're on, the less effective it's going to be. So evolution, and this is kind of the way I think about it, is evolutionary pain is important. You know, think about it in terms of your neurotrophic corneas, right? They don't sense pain. The nerves aren't active. You know, those guys, they don't heal good. You know, pain is there to tell you that something's wrong. So this is kind of like a evolutionary mechanism. There's several theories on why tolerance is built up. My favorite is the concept of phosphorylation. So you can think of it, the down regulation of the G-coupled protein receptors, so that mu, kappa, and delta, they get down regulated. In your clinical experience, or like in your studies, it's like this, it's the opposite, but similar idea with like naftazolin, or like, you know, those drugs like Visine. The more you use it, the more upregulated those receptors on the blood vessels are going to get. So same kind of idea, but opposite. So try to imagine now a patient who's taking opiates, you know, prescription for a legitimate reason, because they've got pain, you know, neck surgery was bad or something, whatever the pain, whatever the cause is, they're taking it. They need to take more. They need to take more. All the meanwhile, they're getting all these psychological effects from it, and it's not really helping their pain as much anymore. And then the dependence on this is huge. So they find themselves like mentally locked. You know, not only do you have like the reward max and the dependence and the pain control happening, like whenever you try to slow down or you don't have it, you've got these really debilitating withdrawal symptoms. And in fact, the withdrawal symptoms, you know, are credited for the reason why people can't get off of this stuff. It's physically, emotionally horrible. Like I've seen these people, it's horrible. So I'm going to review a little bit of the withdrawal time. How are we doing on time?
We're doing good. We, I guess, have about, if you wanted to stop at 50 minutes, we have about 14 more minutes to go.
Perfect. That way we can.
But I do have a couple of questions real quick
Oh,
before we move on to
perfect. Throw it on. Lay it on.
so back to discussing the parasympathetic effects. Why is constipation a side effect if it acts on the parasympathetic system?
No, so it doesn't act on the parasympathetic system per se.
Or acts as a
What
parasympathetic?
I said is there's receptors for the there's mu delta receptors in the hypothalamus and in the trigeminal nerve that are inhibited. And those are in the hypothalamus, that's the origin for the sympathetic chain. And if you're inhibiting the sympathetic chain, the parasympathetic will go.
I see. Okay.
You see what I'm saying? So that's what I meant. So the exact mechanism for constipation, I'm not fully 100% aware, but like what I do know is you do got the gut receptors, and the opiates, they inhibit peristaltic propulsion. So a couple of things happen when you inhibit peristalsis, and that's just the motion and movement of the gut, like the food kind of, or like the bolus or whatever you want to call it is just kind of stuck there. And then when there's an item in the gut, the water gets withdrawn from it. So then you're kind of just stuck. So I'm sure it's like a multi-mechanism thing for the gut.
Okay.
But like I don't know exactly.
The last we had a nice FYI that the Watson on the pill is related to Watson Pharmaceuticals.
Hey, thank you.
Thanks
awesome.
for that, Corey.
Yeah, there you go. See, I'm sure there's some pharmacist PhDs out there, who know more than me. But now I know. Like I was like, why is that there? And like I didn't get too far. Like, I found the picture. I'm like, okay, that makes some sense. But like awesome, Corey. Thank you. All right,
that's it. Yeah, thank you.
Let's go to our opiate withdrawals. So before I kind of get into this, so opiates, unlike like benzos and alcohol, you're not going to die from stopping it, but it's just going to be like a very, very, very horrible experience. There are reports, and there are some patients that can get like an acute pancreatitis, and pancreatitis can put you in the hospital and can kill you, but that's like kind of very rare, and that's like on the extreme end of stuff. But just the withdrawal symptoms themselves are horrible. So let's like kind of take a closer look. So you take your last dose, and then 72 hours in, that's where you're going to have the peak stuff. You're going to feel like you've got the worst flu. And that's where your diarrhea kicks in, because peristalsis kind of starts kind of acting up again or working. And then it's just going to be a flood out. I don't know if you like this part kind of reminds me, I'm old enough in the 90s. If you guys remember that movie Trainspotting, I don't know if any of you guys have seen that, but there's one particular scene, you'll know what I'm talking about. But insomnia kicks in, muscle pains, nausea, and that's when your pupils dilate, because that effect on the receptors isn't happening again. And mind you, these are very, 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 very severe symptoms. They're not like easy to go through. Also not in this slide is the effect of like they really want the drug. So it's the term is like jonesing. They're just like really kind of need it. Like I forget it's slipping my mind the actual medical term if one of you guys want to throw it out there. But within a week, the physical symptoms kind of start to go down, but the psychological symptoms start really kicking in, because think about it, if you're not sleeping, just if you had one of those symptoms, right, from the 72-hour not sleep, like if you haven't slept for a week, you're gonna lose your mind. So these people are tired, they're sweating, their aches are worse, everything's kind of worse, but it's just kind of, it does start to abate a bit. Week 2, the psychological and emotional symptoms, that's really the hallmark, with the depression, anxiety, irritability, restlessness, trouble sleeping. And these symptoms, they can linger for months. Now, one of the issues, right, is even if you didn't have pain, you're going to start getting pain, because these receptors, are pain receptors, and then they're just like hypersensitive at this point. And if you did have pain, well, you're going to have reemergence of pain. So even like the underlying conditions on top of the psychological and emotional and just the distress of needing your medicine, your drug, make it very difficult. And I've never been through anything like this. I've seen people that have gone through it. So we can't, it's hard to judge them, for falling into what they do. And our jobs as providers is to kind of just help them, right? Because they're stuck. So how do we help them? Well, there's medications for that. And there's newer medications for that. And how do they work? Well, we talked about methadone earlier. So methadone is a full agonist, and meaning that it does bind to the receptor very similarly, and doesn't competitively inhibit or anything, just binds to the full receptor. However, it's different. It's got different properties. Less on the euphoria, still has some for the pain and whatnot. But what you can tell from this chart is in higher doses, it's going to have a pretty full effect. So that's where, you can see again, people abusing it, right? In fact, even when I was a resident in ophthalmology and in Pennsylvania, it was kind of like a hot thing that people were buying. I think the going street price was like $20-$30 a pill. They were buying this stuff, to get their fix, even though it was meant to be to help you get off the drug. A newer medicine and a newer line of agents are the partial agonists, where even at full dose, you're not going to get a full opioid effect. And again, just keep in mind, these are less euphoric, so they're less, they could still be abused, but less. And then the other type of treatment, well, is naloxone. So naloxone isn't used for let's say easing someone off of a drug. It's used for rescuing someone who's been overdosed. And you can see that you get zero opioid effect at any level of treatment. So one interesting thing over the past couple of years in Seattle would happen, and that's where I'm from, by the way. So if you haven't kind of caught up to that, but one of the things is they were doing naloxone. They were giving those things away for free in like vending machines, because there's just so much opiate use out there, and they just wanted this stuff kind of ubiquitous, and people ended up stealing them and kind of just, I don't know, it turned out a mess. But the idea is someone's out, you give them this stuff, they're up. It just kind of reverses all the effects, and in some cases puts them into like an acute withdrawal state. So what's happened is, let's say you got this, you got this homeless person is kind of totally knocked out, looks like they're dead. You give them this stuff, they wake up and they're kind of like angry, violent, and not 100% of the time, but this is one of the unfortunate things. So you don't know what to do. But at any rate, naloxone is a complete reversal. One of the newer type of targeting agents are working on the microglia or the glial tissues. So like even the oligodendrocytes, the microglia and astrocytes. So it was always a thought in the past that like these cells were more of like the glue and support structure, but they are neuroplastic, meaning they respond to the environment, and they do modify and do support, communicate to the neurons. So some of the newer drugs are being developed to work on these in conjunction with the actual mu receptors on the neuron. So I think this might be a good spot for our 10 minutes.
Yeah, that's perfect. If we'll ask just a couple of questions and then we'll hit exactly at
Then
that
we'll have
15
our 10 minutes.
Yeah.
I want my 10 minutes.
So one question was if hallucination is a symptom while taking opioids.
There is some kind of like psychedelic, I guess, effect from it. I don't know the extent. Like again, I not an expert on this, but like I do know there is some kind of there is a psychedelic effect.
Okay. And then for
it's hard to say if it's from the actual drug itself or just like long-term use. Like in some of my reading in the past, and that was a little confused. Maybe someone in the audience knows.
Yeah, I did a quick Google of the answer and it said that it's probably underreported and maybe attributed to underlying psychiatric disease rather than maybe a specific side effect of the opioid itself, which I thought was interesting.
Yeah. Well, what we do know is like chronic use does destroy the brain a bit, So, and then what we do know about like psychiatric disorders that do have hallucination as a prominent factor, they are unmasked by the use of drugs. So that could be what that's referring to. But yeah. Okay. Ask me a question I know.
Well, our man Corey had another question,
right,
or had a question. He gave us the Watson tip earlier. So he asked if methadone is helpful for both physical and mental withdrawal issues, or is it mostly physical?
Yes. Okay. Yes, both. Because the thing is, it is an agonist, right? So you are hitting the same receptors. However, it's not as strong of an effect. So, like for example, let's say heroin, I hit that, I'm like super happy. Like this, I take some methadone, I'm still happy, but not super happy, So you're still kind of getting some of that. And that's why, people abuse it. That, and also to kind of keep the withdrawal symptoms out. Like, let's say, they don't want to be fully high, but just partially high.
Okay. Well, cool. Well, let's do our 10-minute break and then we'll see everybody back on at 30 after.
Well, let's talk about the epidemic. All right. Oh, let me see. How come my slides aren't changing? There we go. All right. So this photo was in a local paper. When I say local, Seattle. And this was a neighborhood park that I used to walk my dog to. One of my favorite routines was Saturday morning. I'd go down to sorry. That's my 10-minute. I'd go down to Vita Coffee. I'd grab a coffee with my dog and then we'd go sit and run around in the park. And over the years, it got a little bit more challenging to do that. And what you're seeing in the photos is just a bunch of dirty used needles. And this was not like in scattered around the park. This was just like in one little corner. And mind you, this is a small park that had a daycare center attached to it, and a little play set and a couple park benches. But around town, you started seeing more of this. And like, just even on my same street, $1 million homes, you'd see these things in the gutter. And it just kind of became like a nuisance. It's kind of like a hazard. Like kids see something shiny and orange, pick it up. Dogs, one of my biggest fears was trying to reach into their mouth and grab something like this. Mind you, this is my Seattle perspective. Walking around town, this was not too uncommon. You'd see young people just kind of sitting, bumming around. Some passed out and just seemingly doing nothing. And just the city started getting dirtier and dirtier. And, it's like, what's going on? It's maybe you guys, where you're at, you may have seen this. This is just like, I grabbed it from the internet, but this was an all too very common sight. People just passed out. They look like they're dead. They're not. You just kind of like, I guess, walk by. What do you do in those situations? It's just like it's more and more of this people started seeing. And this is, I'm talking about over the past maybe 8 years or so. It just became a very, very common sight. One thing we didn't kind of, or something you don't commonly think about though, are the kids. They look like normal kids, but like the CDC, after they started kind of getting their attention to this, found that like 1 in 7 high school kids, and these are high school kids, look how young they look, right? 1 in 7 high school kids reported some misuse of an opioid prescription, whether it was grandma's tooth extraction medicine or, back pain thing, they'd find it and somehow get to use it and get their friends to use it. So by the numbers, and this data is 2019, some of it's 2020. And I tried to look for more updates, but it was a little difficult. But I would assume it's probably a little bit more now going through 2020 and, the COVID stuff, but it's huge. Almost 80,000 people died of overdose. Almost 2 million people had some kind of opioid disorder. Almost 1 million people use heroin. Half, like 50,000 people use it for the first time. These are just like yearly stats. It's kind of wild. But when you think about 360 million people in the United States, or whatever that number is, or whatever our census is now, it looks small, but it's still huge. And even in rural towns, this is an issue, not just in the cities. My experience is the city, but the cost to society is big. Not just in terms of like, your friend or family member losing their life or their whole thing going out, but the cost is huge. And you can kind of look at the trends, 11.8 billion to about 80 billion in 2016. So these are healthcare costs, criminal justice, and workplace, like lost work hours. And you might not think about it, but like Medicaid, for example, You get one of these chronic users to the emergency room. Each emergency visit is estimated to be almost $19,000 and costs climbing, and that's just like for like, hey, a quick visit in, because a lot of the patients, even when they would come in and they'd have like some kind of serious eye condition, they'd come in, they'd get assessed, and sometimes they wouldn't even make it to their assessment because they got to wait for us to go and see them. They just bounce, so there's already some like no treatment and high cost. So I'm going to throw this out to y'all, and you could kind of like either answer, or we can just kind of pretend we answered. But how do you treat a corneal abrasion? And how about you? You. How do you treat a corneal abrasion? Let's say someone comes in your clinic. What are you going to do?
So I would first want to know how big it is, if they are a contact lens wearer or not, and how it happens.
Smart. And then what? Okay, they're not a contact lens wearer. They just got a scratch and it hurts.
Okay. So I would probably do a bandage contact lens with a prophylactic antibiotic drop. Perfect.
Now, I like that. I also tell them, artificial tears, lots of preservative-free artificial tears, but that's exactly what I do. Now, what are you going to do if the patients, this is how they spend their whole day? Like they're not going to be taking your antibiotic drops. They're not going to be using their artificial tears. They're not going to be like, would you put a bandage contact lens in this person who's not doing anything?
Seems like their eyes are going to be pretty much shut the entire time. So
they might heal. Yeah, they might heal, right? They might heal. More than likely, they wouldn't have come in, right, if they had a corneal abrasion, because, they're not going to go seek out help for that. If anything that would have brought them in, it could have been unrelated, and then, the emergency room calls you and they've got something like this. They're like, hey doc, come check it out. Their eye is red, So what are you going to do? How would you treat this? Let's say it's not this person, but it's just like your average corneal ulcer. How are you going to treat that?
So I would do a broad spectrum, like fluoroquinolone, like becifloxacin, get some MRSA coverage on there with vancomycin, and then maybe some tobramycin, and just hit it hard.
Perfect. That's pretty much kind of like what I would do. And then just follow them clinically. It's like something you're going to want to see daily. You know my thoughts on cultures, so might share some of that later on in the talk with the group, but broad spectrum coverage. I'd probably throw bandage contact lens on myself. You guys, I'm kind of like a little different cowboy, and then I'd probably get a steroid on there within a day or two.
How do you feel about amniotic membranes in these kind of situations?
I do. I probably would want to see them back first. I wouldn't put it on the get-go. I'd want to make sure my coverage was correct first. I'd want to make sure my coverage was correct first. But I would know they're getting better. How would I know they're getting better, by the way? Let's say I throw on all my coverage, broad spectrum. Let's say I got them on fortifieds. How do I know I'm covering them within the first couple days?
See that the epi defects start to heal and the area of infiltrates resolving.
The first clinical sign of improvement is that your eye is not as hurting as much.
Pain. Okay.
Remember that for our next when we go through this talk.
That might tie in to the opioid talk, huh?
Yeah. So like the first clinical sign of improvement that you're on the track here is that it's not hurting as much. But all right, back to this. So we're talking about drops every hour, right? Now, what if the this is your patient? What are you going to do?
It's a great question. Luckily, I don't think I'll find myself in that scenario, but I'd love to hear what you have to say.
Well, yeah, anybody have any ideas out there? Like, this is your patient. How are you going to fix this?
Guess you'd have to hospitalize them and administer the drops yourself.
So that's the idea, right? I would tell you 90%, maybe even more than 90% of the time, this is not going to keep somebody in the hospital. Like, they are not going to stay. The patient themselves will not stay. They're going to go back out and do this. So for the time that we are fortunate, able to keep them in there long enough to do anything, believe it or not, it's not your drops that we're doing. It's this. It's a Gunderson flap. So that's how I evolved my treatment with some of these folks. You know, they don't need medication for this, right? And if they ever get their act together or life cleaned up, we can reverse that and give them an eyeball. But more often than none, this person, unfortunately, doesn't hang around enough. Like, you know, I would say the maximum that you could time most of these folks are staying in there is about 3 hours, and then they just leave against medical advice. And unfortunately, we're seeing them in there when they look like this. And anybody have an idea what the treatment for this is? Come on, throw me an answer, anybody, before we pick on my co-host friend here.
Help.
Yeah, what's the treatment for this? So this is basically, I'll just tell you. So there's a bunch of purulence, necrotic tissue centrally. There's a hemorrhage, which kind of hints at a rupture, right? Because that blood's coming from the iris. Totally injected eye. This eye was found to, under ultrasound, to be just total endophthalmitis. What do you do with this? Remind you, this is your patient who finally came in. Whoa. Who finally came in. Oh man, I kind of jumped too many screens ahead. Well, the treatment for something like this is this. I guess I do have audio.
We'll be as minutes.
We did have lots of enucleation as answers from our audience here.
Hard to see that, huh? So your eyeball becomes an anatomy lesson in the OR. So that is the inferior oblique that I'm showing a resident, and that's the optic nerve. Let's see. Yeah, that's the superior oblique. Let's see. That doesn't have to be like a super awesome retrobulbar. Let's see. Oh, there we go. Here's the superior oblique. There you see. It could be like 8 hours or so. Here, pull it out. It's not focusing for some reason. We're trying to get an educational video. So basically that's your that's what happens. So you can imagine the costs multiply, right? Of something that was basically an abrasion that could have been healed with artificial tears, a simple antibiotic, maybe a bandage contact. I'd always throw bandage contact in there. I like it. Oh, abrasion, I would do like an amniotic membrane off the bat if their insurance paid for it.
Okay.
But something very simple, drops a few times a day, ends up being something that could either kill them if they don't ever come in for it, or just like a huge hospital bill. So here's another question. How do you treat an itchy eye?
Hey, real quick, before we move to the next question, we had one question. If you're going to prescribe that antibiotic regimen that we discussed with the first ulcer, and say that you're prescribing it, every 1 to 2 hours, how long would you give it before you decide, hey, this is helping improve it, or no, we need to switch course, alter course?
So I don't remember what antibiotic regimen we said, but let's say that first ulcer, if you give them fortifieds, the triple, so Vanc, Tobra, Vori, I would say 99.9% of the time they're going to get better. And usually it's within a course of about 48 hours for something like that, for you to start noticing that the pain gets better.
Okay.
Clinical signs, like you're not going to see much difference. Like it'll still kind of look ugly. It won't look like it's getting better, but they'll start to feel better, you know? And the dosage hours, or how I would dose it, would be I'd give them a loading dose, probably like Q 15 minutes for the first 3 hours. And then for the first, it depends on how bad the ulcer is. I might make them do it overnight, but then I'd go Q hour on that. They're going to get better. I'll guarantee you they're going to get better. With that coverage, they're going to get better.
And you have them take all the drops like 5 minutes apart, or?
Yeah, I say 5 to 10, and especially, I'd have them on the preservative-free artificial tears just to kind of wipe off any toxicity.
Mm-hmm.
But, the only thing you're not covering in something like that is acanthamoeba. And acanthamoeba, there are other clinical signs that will show you. So you can never go wrong with the fortifieds. Moxie is awesome. And I like for that one, in fact, that ulcer, that's probably how I got them better. I give them Vigamox or Moxiflux in Q1 hour. I had the resident write it for them, you know what I mean?
Mm-hmm.
But just for you guys, you can never absolutely ever go wrong with fortifieds. If in question, just shoot it, and then people would think you're awesome and they would think you're super smart, especially down the road. If you needed to refer them out for help, they'll say, oh my God, Dr. So-and-so is super smart.
Cool. All right. That's the question
My
that we have on
question.
those topics. Yeah, that's it.
So my question, how do you treat an itchy eye?
All right. I'll be in the hot seat again.
Yeah.
Wish that we would have reviewed these before so I could have been like keyed up with all the correct best answers possible.
Well, there you go. But I promise not to make fun of you for like wrong answers. And that's like big, that's like one of the things that I like to do is like make fun of people. So
I appreciate it. You can't make fun of a 9-month-old pregnant woman.
Yeah.
Or 9-month pregnant woman. So for this, it would also, depend on severity. If they're just absolutely dying, I would throw a steroid at them to help them have a quick relief. And if it's just kind of like every once in a while my eyes itch, then I would give them like a, Pazeo, something like that.
Cool. Yeah. So like if they were really irritated, I like the steroid idea because you make them happy, and it's going to be not long term. And then for maintenance, artificial tears, depending on the source of the itch.
Right.
This fella, he took his own medical advice and injected heroin into his eyeball.
Oh my God. So
one of the consequences of, being a user is it impairs judgment. He initially presented to a outside hospital, and they're like, okay, we got to send him to Harborview. And then these are the images that were on the outside hospital. You could kind of see a gas bubble in there, but something's already brewing. There's a little bit of swelling. His lens is still kind of detached. This little thing right there, that little white thing, that's his lens. And then by the time he made it to us, the next day, he's just got endophthalmitis, orbital cellulitis, the works, right? Fortunately for him, we were able to get a hold of his mom, and he was not resistant to staying in the hospital with us for treatment. And, the obvious treatment, it was enucleation. That's unfortunate. So those are the medical costs, right? So impaired judgment, you do kind of some stupid things. Impaired judgment, you're not going to take your drops because what's more important is getting high, right? Now, for outside of that, you've got the burden on society, right? So this was a camp. This was even pre-COVID camp that was set up adjacent to a schoolyard. People are they're not able to function normal lives. What they need to do is they need to take their drugs. And they just kind of get together and, there's open drug markets next to schools. There's safety concerns. This camp, got this banned or this, taken down after an 11-year-old girl was assaulted. And that's kind of horrible, right? Well, this is a ring footage from my house. And this guy stealing my Ring camera. And this was kind of like an occurrence on the daily, like people like forget Amazon, I was done with doing that, but like people checking your doors, I finally ended up moving because I had homeless people living in my front yard. And, they got there somehow. But anyhow, how do we get to that point? Like, how do we get to society kind of falling apart, or, not just on the individual level, but like, having zombies walking around or laying around our cities. Well, in the late 90s, pharmaceutical companies, they reassured the medical community about these drugs and said, hey, people are not going to become addicted to opioid pain relievers. And, health providers began prescribing the stuff because, what do we want to do? We're a compassionate group of folks, at least most of us, right? We got into medicine because we want to help people. We don't want them to suffer. And, even when I was a medical student, like this chart was being developed and we were having lectures on it and, early versions of this chart. And pain was becoming introduced as a vital sign. It's like one of those things you checked. You asked them, are you in pain? And philosophically in medicine, you want to alleviate suffering. So it really tied well in with us. We had these medications that we can help folks with. And, at the time, we didn't really totally fully understand the impact of it, but we saw it in little bits. So when I was a resident, in fact, my intern year, I did an intern year in internal medicine. What that is, you do rotate on all the services. So from just general medicine to cardiology, blah, 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 And when we were on call, we'd get called to the emergency room and we'd see a fellow like this. He'd come in and he'd say, oh, what's wrong? And he'd tell, oh, my neck hurts. I'm in a lot of pain. I need some meds. I need my meds. I ran out of them. Well, what are you on? Oxycodone, 10 milligrams. I usually take 3 of those. They knew this stuff. Or, what really helps me is an IV push of XYZ. So seeing people like this in your emergency rooms became a little bit more common. And you're you didn't think it was, you didn't see your grandmas. It was just a certain group of folks. So you didn't really, at least back then, I didn't think it was a big, huge population issue. And it was just the individual. But you got this guy in your ED, what are you going to do? Emergency rooms, you give them your $1 million workup. you find nothing wrong and you send them off on your way. That was one thing. Most providers, or some providers, they just turn their back and say, okay, and they just hop to a different emergency room until they found somebody, who would give them that little bit of medicine that they were looking for. And then over time, and you'd start hearing other stories kind of creep in, as these drugs were being prescribed more often. I remember seeing an ID channel story about a doctor here in Vegas, in fact, who was basically a dope dealer. And, they had like undercover video surveillance of like people going in there and just getting scripts for opiates. So some doctors, were on the tape. They're crooked, they're evil people. They found an opportunity to make money. How horrible that is, but that's what they were doing. Prescribing drugs without any care for the individual or anything, and just making tons of cash. So some people found opportunity. Others, were prescribing because, hey, it's the kind of thing to do. And then all of a sudden your patients are hooked on it. Meanwhile, these pills are everywhere. These medications are everywhere, like every tooth extraction, every little minor procedure, knee procedure, people just getting bottles piled up in their medicine cabinets. And it started becoming more pronounced, like the street impact, like those pictures that I showed you of like people kind of like camping out, not functioning well. And of course, government and local government gets involved. Some things are well intentioned, and then they get policies. I'm sure they had good intention behind them, but they fail because ultimately there's like money to be made, unfortunately, off people, and problems, and so things don't get kind of sorted out too well, and the problem just kind of expands. And at the same time, media is getting a hold of this, right? I don't know if you guys remember this photo. This circulated a few years back. And I remember it was kind of like a clickbait to me. I was like, what is going on here? And how horrible is this? Like, this was like a couple, I forget the actual city this was in, but I was like, are these people dead? So you have these two users in the front seat with the kid. And it was just like a tragic, horrible picture. And more of these things started coming up. And this was like, I want to say this was like 2015 turning to 2016. And then all of a sudden, we had a very, very, very contentious election year. And poof, we had ourselves an epidemic. It all kind of culminated to a point, our politicians, if you remember, they started kind of debating the issue. What are you going to do to fix it? What are you going to do to fix it? Well, the Human Health Services in 2017 declared a public health emergency and announced a 5-point strategy to combat the opioid crisis. Now, I see a question up there.
Yeah, so I was going to wait until you were getting to a stopping point with this, but it is going back to the ulcer.
Oh yeah, okay, yeah, because now we're in stuff. Sorry.
So the question was that using a bandage contact lens for an ulcer, would you say that the antibiotic drops are going to be delivered adequately? And then also, discussing decrease in pain, would the bandage contact lens maybe kind of cover up, kind of falsify maybe where it feels like it's less painful, but it's because of the bandage contact lens?
Those are all very true points. And yes, the penetration is going to be a little bit less. Some people don't tolerate even bandaged contact lenses, and you can get like ischemic toxicity to the cornea, and it will kind of mask some comfort issues. So you gotta be kind of careful. The bandage contact lens, I'll throw it on if Bowman's, if you've already started getting melts beyond Bowman's, that's when I'll go in initially, and I'll use it for more of like a support to help kind of support the cornea, the structure. So more of like kind of like a mechanical. There are times like, depending on my confidence level and if I'm targeting it correctly and how bad it is. So you got to be sparingly. It's not like for everybody, right?
Right.
Yeah.
Then we had another fun fact that picture was from East Liverpool, Ohio, which is one of the attendees' old hometowns.
Well, there you go. So you remember, was I correct in the year? I think it was about 2015, right? See if he answers.
Let's see if he has, yeah.
Or somewhere around there. I just remember sitting in my office going through, the news with my coffee, and I'm like just floored.
Yeah. I remember seeing that picture as well.
Yeah. So media played
before 2016.
Yeah. So media played a very important role in bringing this issue to light. But all right, let's continue, because I still got the meaty part of all of this to get to, and we'll get through the boring part. How much more time do we got before our 50-minute?
Another 18 minutes.
Okay, cool.
17 minutes now.
All right. So the 5-point strategy, here we go. Better prevention, addiction, and recovery services. Our discussion, believe it or not, the reason we're doing this talk falls under this first better prevention bullet point. Better data collection. So that's better pain management. A good portion of my discussion will be, we're going to get into this bullet point, but also better targeting of overdose reversal drugs and better research. So this is what the government said we have to do. So point 1, better prevention, that's our CE. So they said for you guys, I guess it's 3 hours. For us, it's like 2 hours and such. So primary prevention. Preventing substance use disorder is the first step toward addressing overdose. So health providers, under this falls the idea that health providers and prescribers have mandatory education, which is not super horrible, and I hope I haven't bored you too much, okay? Assembly Bill 474, you may have heard about this, says, and this is for the medical, so maybe it's a slightly different for you guys, but for us, it says we need to get about 2 units of CME, or I guess for you guys is CE, per licensing cycle. And bullet point 3, this I believe applies to everybody. All RXs actually bullet 2 also applies for everybody. Every initial prescription, every 90 days during the course, like it's kind of like surveyed and tracked. And then for all new prescriptions, for controlled substances, the forms that you fill out look a little different, and has a little bit more information on them, and it just got a little bit more complicated. One of the things that the Assembly bill did, which I kind of like, because it was the way I thought about it anyway, was factors to consider before prescribing an initial opiate. It's basically the government, asking you to, hey, consider what's medically necessary here. and other treatment options? Or are you masking things? Well, they're asking you to consider all that, but at the same time, they're preserving your medical decision capacity to do stuff, So no one's taking you right away, but they're just asking you to think about it before you, write it up, which is totally reasonable. So let's talk about, to understand, the way I like to look at this is the way I like to think about this whole concept, or the idea of opiates, and it's just try to understand pain in and around the eye. Why is there discomfort here? Are we able to treat the discomfort by better treating the underlying condition and not missing something? So I'll give you the first case. What's our time?
We will stop at 20 after, so 13 more minutes.
Okay, cool. We're gonna get through this guy. So this gentleman, he's laying back in the exam chair, and residents sent me a photo. He was working under with like a hydraulic fluid that was heated and was under a lot of pressure, and the pipe broke and hit him straight in the eye. So if I zoom in a little bit, you could notice that he's got a frozen globe, right? And, he's looking off to the side. They got to pry his eye open. But he's got some thermal injury, and he's got some chemical injury to the surface of the eye, and he's got some blunt force injury. So he's got like a combined mechanism of issues. So narcotics helped this guy. We weren't able to even examine him without giving him some. So initially, we give him some narcotics just to help calm him down and ease some of the pain, so we can look at him. And even in some cases, narcotics aren't even enough to give somebody to examine them. But what we do is we put them to sleep. So that's called an exam under anesthesia. But in this case, we found narcotics to be very useful. And the type of narcotic that we'd give in this situation is Dilaudid. Kind of just calms them down, takes a big edge off the, takes a lot of the edge off the discomfort, and we're able to look. So after we looked, what did we see? Well, this is representative eyeball, but we saw total hyphema. And we were able to find out that his eye pressure was like 60. So where is this gentleman's pain coming from? All right. So it's combined, right? So he's got some pain coming from the skin. He's got some pain coming from the orbit just because of the congestion and swelling and the bruising, and he's got some pain coming from the eye. So let's review everything. All right. So he's definitely got a lot of surface pain because of the chemical injury, right? And the abrasion, total full abrasion. In this particular case, that's what he had. And the chemical injury to, the limbal stem cells and just the surface kind of eaten up. And the trabecular meshwork, from the blunt injury, it's very fragile stuff, right? You're going to get hurt. So it's going to get, your pressures are going to go up, from the iris tear, the blood's going to fill in there. So the pressures are going to go up. So you've got IOP related discomfort. Other things to consider, like, when you get a severe blunt force injury, is trauma to the lens. Does he have a lens rupture? Well, we can't tell. We can't see in there with all the blood. Does he have a lens dislocation? We can't tell. Can't see in there. But those are things to consider. Are you getting pain from that? No. Are you getting pain from the iris tear? Not really, no, because of but you are getting pain from the surface and the IOP in this situation with the eye, right? The ciliary process and ciliary body itself is shut down. So usually after a blunt injury, you get an acute shutdown of the ciliary process, ciliary body, so you're not really making fluid. So his IOP is up either because of trauma to the trabecular meshwork, or just because it's being clogged up by blood or lens material. So continue our review of this case. This is the patient about 2 weeks after. So when I came in, I think I was sent those photos, those initial photos by the residents on the Friday, or no, not Friday, like I want to say Sunday night or something. I don't know. Or maybe it was during the week. I don't recall. But this is 2 weeks after I'd met him. So when I came in, I took him to the OR. He had a lot of limbal stem cell loss. So I gave him a limbal stem cell transplant because his IOP was high and we couldn't look inside his eye. It washed out his AC. So this is him about a few weeks after that procedure. And this is what we see. So what are we looking at? Well, he had a large iridodialysis. That's one thing that we can tell. And his iris kind of rolled up. So this is the posterior aspect of the iris, just kind of curled up on top of the lens. If you recall, the iris, so for him it was blue. The iris has a pigmented bilayer on the posterior aspect of it. So what you're seeing here is that also just tore from down here, rolled up. So that was the source of blood. And the other thing that we notice is that his lens is totally and fully suspended by his iris. All those zonules that you saw, let me see if I can find that picture again. All those zonules that normally hold the lens in place just totally broke off. Now his lens is suspended in the iris, is suspended only by the iris. All right, let's review a little bit our pain management plan here. So narcotics came into play, dilaudid acutely, and Percocet 2 days post-op as a bridge. Till like everything else started working, right? So what did we do? We gave him topical steroids and systemic steroids. So the topical steroids help the inflammation in the eye so that the eye starts to feel better, right? And it's part of the healing regimen for post-op procedure when we do a debridement of the ocular surface and periocular tissue. And we're doing a limbal stem cell transplant. So that's part of the thing. And it helps calm down everything, keeps the eye, helps with comfort because inflammation is a source of discomfort. Cycloplegia for any of the ciliary spasm that he was getting, because, blunt injury does hurt. IOP meds, to help calm things down. And, at this point, wasn't complete. He did have enough trabecular meshwork damage to where he lost majority of function of the trabecular meshwork. So he still needed to be on IOP meds before we're giving him a tube. And then surgery. Surgery played a major role in kind of helping remove necrotic tissue, which caused inflammation, which caused pain. But in every pain management plan, especially if you're using narcotics, the most important thing is counseling. So what I tell patients is, look, you're going to be on these pills. So like when I say Percocet for 2 days, I probably gave him 4 tablets. I said, look, I'm going to give you 4 tablets. And that's all you're going to get. You're not going to need any more because you're going to get better. And if you don't get better, the treatment for this is, well, a blind eye. At this point, he's still blind, right? So kind of just tell him treatment for pain that's irretractable for treatment is removal of the eye. Nobody wants to really remove their eye, so they kind of go in there thinking, I'm going to get better. So counseling is kind of very, very important. Where are we at with our time?
Just about 4 more minutes.
Okay, well, we could start talking about how, if you guys are interested, how do we get an eye that looks like that to see better? You guys interested in knowing?
Oh, yeah.
Yeah, all right. So this is a screenshot that I took from the video of when I was doing this case. So, these patients drepped and prepped, and this is like a couple months out now. No, actually, yeah, I don't remember how long out, but like you could see that the lens is intumescent. So normally lenses are flat. So the anterior posterior distance is short. So it's about maybe let's say about 4 millimeters this way. It's about the size of a dime in the longitudinal aspect. But because this lens is a traumatic, and it's not being stretched longwise, it's like a marble. It was like a marble in there. And so how do we fix that? Well, a lot of people would just say, hey, let's do a vitrectomy. Let's get rid of the lens, send them to the retina surgeon and let's get rid of the lens that way. But vitrectomies aren't all that great if you can avoid them. And because I had a lot of cases like this, or similar cases, developed certain techniques to kind of get around this. Now, any surgeon that operates on this stuff or knows about an intumescent lens don't want to touch it. Because if you think about it, what's happening is the protein inside that lens, when it's white and swollen like that, like a ball, it's like you could imagine it being like filled with pressure. Because what happened is fluid is rushing, or fluid is collecting inside this ball, so that like any attempt to kind of open that capsule to get into the lens is just going to explode. Now, I don't know if you could see here in this, but do you see there's a blue stain? So there's a blue type of stain that we use. It's called trypan blue to stain the capsule so that you can see it. Because usually you rely on being able to see the capsule from the red reflex, but there's no red reflex here, right? So we stain the capsule. But if you could see, there's a capsulorhexis now. See this circular thing? Well, normally to get a capsulorhexis, you make a little mark and then you just peel it away. But how are you able to do that in this situation? Especially like most cases, if you rupture right into it, it's just going to split open, you lose your capsule, and then it's a retina surgery. So I developed this technique. I'm not going to get too much into detail for it because you guys aren't probably going to care too much, but it's basically a summation of forces of vectors where you tug and grab really quickly, and this whole circular thing happens in one fell swoop. Whereas a normal capsulorhexis, you kind of walk it around, in a circle. This is just you grab it in a certain spot and you pull it in such a direction that this whole thing happens in just like a fraction of a second. Like, I don't show you the video because you can't even really see it under the video because it's just like one quick swoop. So my joke is femto laser, right, can do a capsulotomy in 1.67 seconds, or at least that's our machine now, our Catalyst machine. It's like about 1.67 seconds. This is under a second. So this is the fastest capsulorhexis you're going to get, and it's done by hand. Like I can't do it in a normal eye. It has to be in an intumescent lens. So now you've got a lens, right, that's attached to an iris and just kind of floating and bobbing in there. How do you get the lens material out of there. Because if you know, when we do cataract surgery, we come in with a phaco device, and the phaco device is irrigating fluid in there. So if you're going to irrigate fluid in there, it's just that pressure in the anterior chamber is going to push that lens back, and it's going to drop into the back of the eye, and then you got a retina case, right? So these are capsular bag hooks, and they're very, very nifty devices which can suspend the bag. And this is a capsular tension ring, which is a very nifty device, allowing us to give more support to the capsular bag and suture the capsular bag in place. I'll show you some videos here. So this is a video of after the capsulotomy. I put the capsular tension of bag hooks in. And normally what we do is called the hydrodissection, like flushing the lens really quickly to peel it from the capsular bag. But we can't do that in this situation because the lens will drop. So in this technique, I call it dry dissection. You won't be able to Google that because I haven't published it. But after I do this dry dissection, I use this aspiration unit with very, 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 very minimal irrigation to just start sucking some of that lens material out. And we're not, if you notice, I'm not using any phaco unit, so no ultrasound energy required, but just very gentle manipulation of the lens to kind of pull it out. I wonder if there's a way to mute this for you guys. You don't have to hear my static. There we go. So normal cataract surgery takes me anywhere between 6 to 12 minutes, 10 minutes, 11 minutes. Here's the capsular tension ring going in. You have to remove some lens material from the bag before you put the tension ring in. And then that tension ring, we have a substance in there so that we can fixate the bag to the eye. But what I was saying is normal cataract surgery takes me anywhere between 6 to 10 minutes. Maybe if I'm doing aura or something else, maybe 11, 12. When I first started doing these procedures, like this particular gentleman took me about 45 minutes. Something like this when I first started doing something of these type of procedures. But toward the end, I was getting these cases down in about 25 minutes. You get good at it, and you kind of figure things out. But remember, we said phaco unit, we aspirate stuff out. It just kind of sucks stuff out. This is a gentle process where you're just flushing the eye out you're flushing the lens material out of the eye rather than using a machine. So you have to be very gentle and careful. I think I could skip to the next. I think you saw enough. I don't want to bore you too much. So this is the patient I would say about maybe 3 months after I'd given him a PK and done that procedure that you saw on. And his uncorrected vision, believe it or not, and I lie to you not, on the day of this photo was 2025. It was probably one of the more incredible outcomes I've ever had with a PK, but let alone with an injury like that. So he'd gone through limbal stem cell transplant. He'd gone through, that procedure that I showed you where we fixated the capsular bag to the eye and then, give him put a lens in his eye, put a lens in the bag. And a few months, maybe a few weeks before my PK, I don't recall, one of my colleagues gave him a tube and I did the PK, but at this point he was 2025. Any questions? And then before our little 5 or 10 minute break, do we have enough time for a 10-minute break or are we going over?
We could still do a 10-minute break.
Cool.
For sure. One question was going back to the opioids, how different are the results of an NSAID inhibitor or inhibition of the COX-2 compared to the opioid receptor targets for pain management?
I don't even know how to answer that question. That's too technical for me. I'm kind of I don't know. But I can tell you, opioids are really, really good for all forms of pain, right? And I would use those more in the acute setting. And like, for example, like if people have like fractures or stuff like that, the NSAIDs are fantastic for like that type of bone pain. You know what I mean? So I think about it that way. I don't know the pharmacodynamics or kinetics of any of this stuff. So.
Mm-hmm. Yeah, I remember I took a opioid course that was required by our state. I guess it was last year. And they talked about alternating NSAIDs and Tylenol in such a way that would have a very similar effect as what an opioid would. And that's what I guess a lot of dentistry uses now.
Yeah. So like I'll do something similar. So like I'll have patients kind of do ibuprofen and Tylenol, you know. But you know, in the outpatient setting, like in ophthalmology, there's not too many instances where you need to do something like that. You know what I mean? Even opiates, as you can kind of see already, right? People are going to get better. You're going to treat their ulcer. Their pain's going to improve. And even like Tylenol and any NSAID is not going to help too much with like corneal discomfort, you know, maybe a little bit. I don't use topical NSAIDs too much to control pain because they inhibit wound healing. But I don't know.
I think it's a nice response to be able to have, though, if you have that uncomfortable situation where someone really is, you know, asking for pain medication, maybe abusing it some, or maybe to give them a little bit of peace, that you can use these over-the-counter products that would have a similar effect, but maybe less of the side effects. Or
I tell them there's not much that's going to help you, and that's just my honest. Sure, you give them a narcotic, it's going to help a little. It's going to take some of the edge off, but like it's just not good practice. And as you'll see in the later slides. Cool. Any other questions before our break?
That was all the questions that I saw. Let me just double check.
Let's move on to our next case. So this is the gentleman that we were introduced to from our pretest. So just to summarize, his clinical scenario was he was ejected from a motor vehicle at high speeds, literally fractured his face in half. Most of the time we don't, as ophthalmologists or eye care providers, see anybody in this severe of a state because, you know, they die, but he happened to survive. He was intubated on the scene through his orbit. So like when I first, at this point, he was trached. So like what they do is they put an airway in there, but on the scene, like when I first walked in before we took the photos, he had a tube sticking literally down through his orbit, and that was providing him life support. This was a project. It wasn't just like a one-day kind of thing, you know, to try to fix. And it was a multi-team approach. You know, I was involved in the orbit reconstruction, removal of the eye, and, you know, and the aftercare of the patient. So immediately post-op, you know, and we put him somewhat back together. And this is his clinical photo on the day of discharge. This is a little bit of a photo. I'm trying to show what it looked like inside of his orbit. You can still see some kind of, there's mostly mucus, some granulation tissue kind of growing in. He did not have an implant at this time. Put that in at a later date. Actually, we had to be really creative on how we put this guy's orbit back together. We used some 3D printing, had some custom parts made, but at any rate, let's talk about our pain management here. So that's probably the most severe eye face kind of thing you're ever going to encounter, you know. And this is what happened to him. This was his hospital course. So he had about a 2 to 3 week taper of narcotics in the post-op period. So it was more morphine, then oxycodone, and then Percocet. So the most severe facial eye issue, 2 to 3 weeks. After that, it was pretty much Tylenol for bone pain. We had him on low-dose prednisone for facial swelling and pain and discomfort associated with that. And also, you know, just to kind of get the swelling down so we could see what our work looked like, if we need to reconstruct some more and whatnot. But more long-term, it was gabapentin. You know, as nerves regenerate, and just the type of pain he was having was related more or less to nerve issues. So gabapentin played a fairly significant role here. And more acutely were the narcotics. So without narcotics, you know, there's no way, there's nothing we could have done for this guy. Just keep him in a coma. And even in a coma, he would be suffering. You know, people are kind of still somewhat aware what's going on, you know, so thank God for these medicines, and they're absolutely needed. And of course, counseling. So he was married, I presume still is, and the counseling was involved with him and his wife. You know, he did have some traumatic brain injury, but was still cognizant enough of, you know, to answer your questions, able to talk, hold discussions, but he was a little slower, as you can imagine, you know, not the same individual he was. And counseling really involved, was really geared around the idea of how are we getting you better and how are we controlling your pain? And really telling him, look, there's no role for these narcotics and you don't need them anymore. So whenever any patient I would have initially on narcotics, that would be the first discussion, is like, we're going to use these for an X amount of time and we're not going to use them after. We're going to get you better and you're not going to need them. So with patients, you know, reasonable people going into this type of thing, that it makes sense to them as well. So moving on, let's talk about the next patient. So this gentleman presented to me in my clinic. You know, that was so, you know, average day, I'd probably at that time in that half day had maybe like 30 patients or so. So he was a referral. 1 month prior to his, you know, whatever happened to him here, he'd seen an eye doctor after getting cement in his eye. So he's a construction worker and got wet cement into his eye. It was really kind of unclear if he'd had any procedures done at the time or whatnot, but he came to me with severe pain. He was on Durezol only and had an IOP of 50 and was popping Percocets left and right. And it's a little difficult to tell from the picture, but let's see what's going on. All right. So is developing some pannus. His cornea is hazy. It's really hard to tell, like, you know, you can't really see any of the limbal structures or vessels still present. And his upper lid is absolutely fused to his globe. So he'd lost the fornix, his upper fornix. He's lost partial of his lower fornix, and it was just it was very, 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 very uncomfortable. So where does his sources of pain come from? Let's review. So surface, obviously, right? So he had a lot of inflammation, a lot of inflammatory process going on. Internally, IOP is 60, so he'd had something funny going on. Why was his IOP 60? Was it because of the Durezol or was it because of the chemical injury? So cement is an alkali agent, and alkali agents, what we know about those is they penetrate deep into the tissue. Again, it gets to our friend, the trabecular meshwork could damage them. He could also be having pain just because of necrosis to the internal structures of the eye, because base, if it's not properly irrigated or debrided from the eye, it just keeps penetrating deep. So there's an element of ciliary spasm because of inflammation, or maybe just inflammation secondary to the outside, or inflammation secondary to internal necrosis. Hard to tell. But anyhow, how do you prevent a situation like this? A patient eye looking horrible, in pain, abusing narcotics for over a period of a month, and IOP of 50. Well, regardless of the agent that you're going to get on your eye, whether it be an acid or base, you're going to want to irrigate the crap out of it. There are various devices that emergency rooms use to try to flush eyeballs out. My favorite really is just getting a bottle of saline and putting a nozzle on it and just squirting the hell out of the eye. I'd have the residents sit there, bottle after bottle after bottle, just irrigating and irrigating and irrigating. I don't particularly like these devices that you see here because they could they sometimes result in secondary injuries and erosions and ulcerations, in fact, if not used properly. But like the best thing to do is just flush. If you're at home, garden hose, sink, toilet water, it doesn't matter. You just got to wash the offending agent out of the eye. That's the most important thing. And then you get to somebody who knows how to treat you. So how do you prevent an eye that looks like this already from ending up like this? Well, in the acute phases, whenever someone came in with any type of chemical injury, we debride it, whether it be bedside or in the OR, we debride it. In fact, I train the residents for them what to do is just even in an emergency room after you got them under the narcotics, some IV push medicine and topical agents. So just take a 4x4, which is basically, it's like gauze, but it's kind of like a rough sandpaper surface, just to even just start brushing the surface of the eye to kind of debride whatever's loose or already necrotic off the surface of the eye. And get a bloody surface if you have to, just to get that stuff off of there, and then irrigate and irrigate and irrigate with as much saline as you can. There are chemical strips or pH strips that you could do to check pHs as you're going along, and your goal is to get to N0. But for this particular fellow, he already ended up like this with me, what did I do? Let's see. Let's go through that. Let me mute. All right. So what you see here is infiltrating the ocular surface with epinephrine and lidocaine. The epinephrine serves to hold the medication there, and The medication really serves two purposes. One, the epinephrine to minimize as much bleeding as possible, but also to kind of bubble up the surface, give you a little bit better dissection plane. One thing that you notice, you could see, it's hard to tell from the initial photos, but look how much tissue grew over the cornea. So you could see I'm dissecting back. And that's cornea there. And we had like just scar tissue growing over the cornea. I know it almost looked like a normal cornea, but that's a few millimeters of tissue. So this, what I'm holding there in the forceps, is primarily just adhesion and scar. So tenons is this is tenons being held there, and tenons is normally supposed to be very loose, but this stuff turned into more of like a cowhide. And you can see that the lower eyelid margin is here, like if the eyelid was inverted, and this scar was basically freezing the globe. So we're just kind of dissecting it away. Why did he get all this? Well, it's the cement. All that's alkali agent kind of penetrated back. Now we have a free, normal-looking eyelid after we cut it out. It's extensive dissection. And actually normal, almost pretty kind of normal-looking eyeball at this point. So he had a lot of limbal stem cell loss. I would say probably 80%, all these clock hours. And how do we prevent this eye from, adhesing again? Well, this is dry amnion. I'm gonna glue it to the surface of the eyelid because that was all debrided. And we need a substrate so that we don't form an adhesion. And that's biological glue. It consists of fibrin. And then we harvest stem cells from the good eye. Fortunately for him, he did have a good eye and conjunctival tissue. So that when we put it back to the other side, he doesn't form a new adhesion. Because if you just have two non-epithelialized surface, like palpebral conge and bulbar conge, if they're non-epithelialized and they come in contact, you'll form an adhesion. So this is this basic limbal stem cell graft. And I mark it blue so I know the orientation of where the limbal stem cells are. And it was a deep dissection. You didn't see that in the video. There was a crescent blade to kind of cut deep. And more stem cells harvested from the other eye. All right. I don't believe I have an after photo for him, but he was a 23-year-old male, and there was a lot of follow-up with him. And I'd say about 6 months after that procedure, he sent me a photo from his wedding, and he had a nice white quiet eye. Yeah, I wish I somewhere in my files I may have a post-op for him, but he looked actually quite normal and did quite well. So pain management, narcs, I would, I wouldn't have given him any to start off. I would have gone into the surgical debridement. If anything, maybe I would have given him a couple tablets for the first couple days post-op, but he would have done quite well if he would have had early surgical debridement, topical steroids, cycloplegia, and Tylenol, just over-the-counter NSAID pills. Counseling was big for him because he was already somewhat dependent on the stuff. And it was a cold turkey stop because I told him, look, I'm going to help you. I'm going to give you your eyeball, but we're going to not use this stuff anymore. We don't need this. And he was game plan for it. Any questions about that case?
One of the questions that we did have come in was any concerns of the retina with alkaline injuries?
Yeah, you can. You'll see what in the next case. Actually, that stuff can totally get in there very, very deep.
Okay. That is all that we have for now.
All right. So this is probably one of the more severe cases that I've ever seen from alkali injury. And this, granted, this is a bilateral. So both eyes look the same. And this young woman, I think she was in her mid-20s, married from Portugal, living in the States under a student visa graduate program. And she was making soap, homemade soap. She put her ingredients into a blender, one of which is potassium hydroxide, a really, really, really strong base. And how it was described to me is it just blew up. So some of this stuff, like if you mix it aggressively, can kind of heat and kind of blow up. I don't know if the lid came off or the glass, everything, but anyhow, she got this stuff into her eyes. And this is within the first 12 hours actually of injury. What do you see? Well, let's talk about the skin first. Yeah, this was over the weekend. This is a resident holding and sending me the picture and asking me, hey, what do we do with this? But anyhow, let's look at the eyelid. So do you see how it's all gray? And all gray, she ended up losing all of this tissue because it's just the alkali agent was so strong and it just necrosed the tissue. It penetrated deep and necrosed the tissue. What is this black thing here? Anybody?
I was gonna say
Or
choroid,
dark
but
brown?
it's very distinct.
Yeah. What is this? What is that brown thing? That's a pretty good guess. That's what the resident thought.
Is it the lens?
No, so that's actually blood.
Oh my gosh.
So that's blood. So the inferior rectus, and even around her recti, we had this coagulated blood underneath whatever remained of the conjunctiva. This eye is not going to do well at all because, well, we don't see any limbus. There are no limbal stem cells present. I took her to the OR to see what we can kind of salvage and do within the first, I would say 6 hours of this injury. And it was an exam I'd never forget. So there were pigment cells floating around in her AC, and that was her iris that already began to disintegrate.
Ugh.
Her lens was already liquefied, and her eye was super soft to touch. What we did, I ended up doing amniotic grafts over maybe 2 or 3. I wasn't hoping to get much. It was more of kind of buy time and kind of let this for this patient and her husband to kind of come to terms with what's going on. Very, very, very horrible. So yeah, base can penetrate very, very deep into the eye. We did do ultrasounds of her eyes. Her eyes, she had choroidals, so the choroids was swollen, the retinas were detached. It was just an absolute mess. So I'll throw a question out there for you guys. What kind of pain management did we need for her ocular surface after her eyelids were healed-ish? So believe it or not, she had no pain.
I was wondering, does it just like melt all the
Everything, yeah.
nerves
So all the nerves were dead.
Mhm.
Even after the initial burn. So like at the edges of this, there was really no discomfort. So it was just kind of like Maxitrol ointment to the lids. And then eventually, this necrosed tissue kind of just left. So we had
What about
no.
What about tarsorrhaphy? Would you consider that?
There was we didn't need to do that. We didn't really need to do any of that. It was just more supportive at that point. And then she ended up going back to her home country to undergo some experimental stuff. I don't know what, but yeah, we didn't need to do anything. And I followed her for about 2 months. There was some acute pain involved, and there was narcotics in the ER given. But over the course of my clinical care with her, I didn't have any narcotic prescriptions given out to her. Here's a more common thing that would happen. We're at my institution, we'd see this very often, and this was a motor vehicle accident. Steering wheel to face to eyeball, ruptured globe. We'd see it also because of, humans are bad to each other. Sometimes they get into altercations and they do bad things to each other. Whether it would have been a fist, a knife, or whatnot, we call this an open globe. So this is probably like a very severe open globe where the eye is going to be eventually lost. But in this situation, I have a question for y'alls. Are narcotics indicated, and for how long do you think? The most severe eye injury that you can possibly get, let's just assume this is isolated, no fractures, nothing. Worst thing that can happen to an eyeball. Well, this was my usual routine. If you go to the bottom line here, whenever anybody had an open globe and we were going to repair, I discharge them with 12 tablets. I tell them 1 to 2 tablets, 4 to 6 times a day. Or no, not 4 to 6 times a day, 1 to 2 tablets every 4 to 6 hours. Bandage, contact lens. If there was, corneal sutures, and that was pretty much it. The bigger part of the counseling for blinding or near blinding injuries to the eye was, hey, look, the way that we control pain is with eye drops and you getting better. If you don't get better, after X amount of time, which you should get better, because invariably they do. It's just very, very, very rare you have to remove an eye for pain, but the treatment for chronic eye pain is removal of an eye. And that's what you got to that's what we hammered in. And we rarely ended up having to take out any eyeballs. And most people, because I tell them, look, you use these pills only if you need them. Take them if you need them. If you don't take them. And I would say the majority of patients, they might use them for a couple days. They might not even, because they were just into their drops and they just wanted to get better. And then if they didn't get better and it was a blind eye, well, blind, painful eye, how do we treat a blind, painful eye? I'll ask you, my co-host, how do we treat a blind, painful eye?
Nucleation.
There we go. All right.
Oh.
So that is the lateral rectus isolated. And now we're isolating the inferior rectus with a muscle hook. That's called a Jameson muscle hook. And that's just Q-tip, you peel off tenons. This looks like a younger patient. I don't recall. We made this educational video for, I don't know, one reason or another. And that's, this is one of the procedures that you, as a resident, you get to start doing it in your first year. And this is the resident cutting the muscle, freeing the muscle off the eye, if you're wondering. And that's me kind of, this is me holding them. I'm kind of telling them what to do. But they're still nervous. That's one procedure you can't really mess up, you know, the eyeball, because you're taking it out. So I'd probably do one or two of these a month just for education and just to kind of like teach the resident, give them something to do, especially if they're a resident and they were working hard. So that's called a bulldog. It just holds the string or the suture out of the way. This was the attending spot. So I'm strumming the optic nerve with the scissors.
One question that we had as we were watching this video is, would you consider evisceration versus?
Yeah, we do eviscerations. I was a fan more of an in-nuke. I'd give the patient the option, you know, what they wanted. But yeah, eviscerations are fine. They're, you know, in my clinical experience and what I've done, I find them to be very equivalent, you know, in terms of like cosmetic outcome. It's just patient preference.
Okay. And then another question was, is
that's an orbital sizer. How's that?
Another question was if a retrobulbar alcohol block is still an option for enucleation for the pain.
You know, I don't do those. The main reason is when you do it, it hurts a lot. I've played around with that clinically in the past on very few patients, and really what I found is you needed multiple treatments, and it was rare when it worked.
Okay.
You know, and if it did work, cool. But if not, it just kind of like drawn out and it's not comfortable. Like the alcohol hurts back there, you know. So, and even after, so you combine it with the anesthetic, and after the anesthetic wears off, they're uncomfortable. But that is still an option. Some people do it. I just don't. And I don't really know anybody that does, for the reasons that I mentioned.
It's interesting. It's interesting the stuff that we learn, you know, very academically versus.
Yeah, no, I know. And I learned the same thing academically too, you know. I ended up breaking so many academic rules that it's crazy.
Just throw in that Will's Eye manual.
Well, no, Will's Eye is actually pretty good. It's really, really good. But yeah, there's so many things that I learned academically that I just broke all those rules. And it's kind of funny when I talk to other clinicians who are out in like private practice world, they go by the rules, you know what I mean? So like I came from a place where we're meant to break the rules, you know, and they're like, wow, you guys did that, you did this, you did that. Yeah. And they're like, how come I don't know about that? I'm like, well, I didn't write about it yet, you know, or I'm not probably going to write about it either. But like, yeah, that's eye care for you. But so what am I holding here? So let's back up. This is kind of interesting because you won't see this. So this is a sizer. It's a 22 millimeter sizer. So you kind of size what kind of implant you're going to put in. And my favorite type of implants were the silicone because they're very inert. And goes in very nice and lovely. I'll show you another case where later on, but for pain management, in this case, what do you think narcotics are appropriate or no narcotics at this point?
I'd say no.
Yeah, so I would say it depends. I would say most young people And when I say young, I would say under 65, actually maybe yeah, let's say 65. Under 65 do require some amount of pain control. I used to universally give Percocets just for about 3 to 4 days worth. So maybe like 6 to 8 tablets. And I found that half of that population that I just mentioned would end up going through all of it. Rarely needed any more. And it was just like acutely in the post-op period, they tended to need it. Most patients, maybe they would do it on the first day after they wake up, because I do use a lot of local. There are special circumstances that I'll discuss a little bit later. I'll show you a slide where you don't need narcotics for this. Here's another injury to the eye, very similar to that guy that we saw earlier, except he doesn't have a liquefied lens. This is a post-op period. This is a post-op picture immediately after the globe was repaired and the AC was washed out. It actually looks really good, but a question comes up. What is the immediate post-op pain plan for an eye that suffered a similar injury? Let's see if you guys kind of remember. And this is bad. Like, look at this, all this iridodialysis.
Going to see if we'd have anybody in the audience say anything.
Let's see if y'all remember. Now this is severe, right? You know, this was a laceration. This was a blunt injury, and the limbus fractured. So if you remember from your anatomy books, there's a few weak points in the eye. Where the eye is a little thin, so the limbus is one of them. The optic nerve is another one, and then at some insertion points with the muscles too. So if you're going to find a rupture to the globe, it's going to be at those from a blunt trauma. But yeah, this was severe injury, and just to kind of throw it up again, for the open globes, right? This person did get a BCL because there was corneal sutures involved, or limbal sutures. Really what's going to kind of get us pain-free is the steroids. But to kick in, I did always, universally give these people some tablets. Did they use it? Some of them did, some of them didn't, but they had it there. And I would say it is medically necessary in most patients. And most important, what's the most important thing? Hint, 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 is the counseling, right? You want your eye to get better. We want your eye to get better. The way that we control your pain is by getting your eye better with the medications, right? Question, how do we get this guy's vision better? Well, very carefully. So if you notice here, it's not a liquid lens, and we do have to do phaco. And this is just a very, very, very slow chop, like styled technique. This was an older gentleman, and he had already had like a somewhat of a dense cataract. So I'll tell you, there's not too many anterior segment surgeons that would go in there, and rightfully so, they shouldn't, unless they kind of knew what they were doing here, because you're looking at more trouble. But this guy, I want, what's our time? For time's sake, I'm going to move on. But he ended up doing quite well. I have a question for you guys. So we look at this eye, right? He's got his sutures there. Eventually, I took those sutures out and took the suture out. But what do you see is missing half his iris, right? So here's one question for you. A few months down the road, after I yagged him, I'm not going to tell you what his vision was yet, but like a few months down the road, is he having any light sensitivity issues?
I would assume so.
You would, right?
I guess unless his acuities were so bad.
His acuity after YAG uncorrected with no scleral lens or anything was 20/40.
Yeah, then I would assume he would have some pretty significant light
That's
sensitivity.
what you would, and I used to assume that too. I can't tell you how many eyeballs I've had like this. I didn't keep track. But that was one universal finding is they didn't.
Interesting.
Yeah, on rare occasion they did. And then I'd send them to my friendly ODs, where we would get them those contact lenses that had like the fake pupil on there, so to occlude all the light.
Yeah.
But that was like very rare. And in the instances where we did, eventually those patients stopped using those. Yeah, that's just kind of like an interesting little tidbit. But all right. Now, granted, so this was a cataract surgery done on a post-traumatic eye. Like, like the trauma happened, we let the eye kind of settle down. And I started moving more toward letting the eye settle down, irregardless of the trauma, just to kind of calm it down. And then I would do any intraocular procedures if I could wait. But they had a peculiar instance. It's not like normal cataract surgery. And I would say more often than not, they did have post-op pain that was not controlled by cycloplegics, by steroids or anything. And that was more or less in the acute period. And I would give them Percocets just for about 1 to 2 days. So that's one interesting tidbit. I don't think you guys would come across too much of that, but there you have it. Where cataract surgery needs pain control in a post-traumatic eye. Let's move on because I want to show you some cool stuff and we're getting close toward the end. So this looks like a burn patient, but it's not. This is a Stevens-Johnson patient who's in a coma under high doses of narcotics. Stevens-Johnson, well, it affects the skin and mucous membranes. And this is what the mucous membranes look like. So epithelium and conjunctiva are considered, corneal epithelium and conjunctiva are considered mucous membranes and are affected. So this is an exudative necrosis of the conjunctiva. And what we do in these situations, and one thing I didn't tell you, but like I was the regional specialist for acute and long-term management for Stevens-Johnson's graft versus host and whatnot. But anyhow, what we do for these patients is we would do amniotic grafting. So if in this particular case, this person required some debridement, but in most cases we didn't need to. And we do amniotic graft. So if the patient is able, if we're able to move the patient, because sometimes you can't move the patient because their skins are, their skin everywhere is sloughing off. We can't take them from one bed to another, and they're very, very critical. We'd have to do it in the bedside. And in those cases, if it was then done in the bedside, thank God for fellows. So to have the fellow do it, because it was kind of like awkward and uncomfortable. And like, I'm an old guy, right? I don't want to hurt my back. So I have the fellow do it. But if it was an OR, I'd take them, those are good opportunities to teach residents and do. But at any rate, we'd, like you could see the amniotic membrane here. So it was, try to bear with me here. So palpebral. So you would cover the from lid margin all the way through the fornices, across the globe, and across the lid margin. So you'd cover the entire ocular surface from lid margin to lid margin with the amniotic membrane, and you do several grafts as needed. And this was the same patient. And this is what you'd end up looking like after doing that. And there's intense medical therapy involved. We ended up getting a protocol written in place where I found that these patients did really, really well with high dose systemic steroids initially. So where in instances where it wasn't contraindicated because of other systemic disease factors, these patients were started on high systemic steroids off the bat. But we did a lot of topical medication at the same time this was going on. But they'd end up like this. Now, this, after, the advent of amniotic grafting and whatnot, we didn't have much in terms of issues in the acute phase. It was really the chronic phase that was the problem. Now, this is kind of a red hot looking eye in a monocular patient. What do you see is just, really significant blepharitis. But if you pay attention closely, there's a little divot there. Let's move in. Oh yeah, and matarosis, the inflammation was so bad, she lost her lashes. And she was monocular because she'd had a suicide attempt a few years prior. And, kind of missed the brain but hit the eye situation. But you see a melt, a sterile melt. So in ocular surface inflammation, if it's very, very, very significant, you can get melts. I've seen it in blepharitis a few times. And that's how I modeled my therapy for this patient, was based on that. And then just kind of applied it moving forward. But let's take a closer look and see if you guys can see. So basically she had a dysmetacele. One thing about, being in a fancy clinic, we've got anterior segment OCT. And I was able to actually kind of just track her treatment progress. The way I got her to get better, it's kind of a little too much for this talk. And I've got a bunch of other cases I want to show you. But I want to ask you a question. For this particular patient, was narcotic treatment necessary? Not needed for the eyes, surprisingly. So it was, in this particular situation, she didn't need it for the eye pain. And most patients don't in this situation. I say plus or minus, and bridge is inpatient, because they're like some people have like a tad bit of anxiety and discomfort when you're kind of looking at their eyes. And it was helpful for like the examination process and trying not to rupture the eye. But it's really a systemic disease, and you treat systemically. Now here's an interesting case. We're getting close to the end of our talk, aren't we? Our moderator?
Yes, so it will end at 30 after. That will be our.
All right, I'm going to try to keep you maybe an extra 10 minutes because I'll show you a couple cool cases. Okay. So this gentleman presented with a friend of his to the clinic. And if you see, he's got a red hot looking eyeball and an open globe. It's just because of a sterile melt. I'm going to throw a question at you. What type of pain medication is indicated in this patient? So I'm going to say none. Let's go. I'm going to say none, because this was a neurotrophic ulcer that totally melted. He was in zero pain. his friend that brought him in was trying to tell me he was in pain and he wanted some pills for his pain. And this guy's just sitting there smiling and he was super happy. But I don't have much time to go over how I treated this, except I'll just tell you that I accidentally discovered a way to fix that using amniotic membrane. And this was his end result. He actually had an eyeball, because you can't really cornea transplant those guys. He had a few weeks out, he did have a formed chamber, and he did quite well. And then subsequently, I gave him a lateral tarsorrhaphy, and I followed him for a couple of years after, and he did fine. So, pain management plan, none needed. Let me get into this guy. So I remember, you recall the autoenucleation, right? Now here's a unique scenario. People, and this was 100% of the time, I can't tell you how many times I've seen this. I would say maybe like 10. And this wasn't even the most severe. So I've had other patients, they take box cutters to their eyeballs. I had one guy, he did a box cutter to his eye and then cut off his thing. You know, people, in acute psychosis, they do this stuff. Universally, they do not require pain medications. It's just a population where like they don't have pain with this. So this guy did not need any pain. He ended up doing quite well. And it was just, there was no surgical intervention. It was just repositioning of the eyes and systemic steroids that were involved in treatment of this guy. And I did a few conferences with interpreters to mainland China to talk to his parents and tell him what was going on. But he was very, very interested in getting better. And after he was aware of what was going on and his psychosis was treated, but he did quite well. So in summary, what type of pain medication is needed? None. That's a surprise. So there's no pain in neurotrophic disease, psychosis. Elderly is one big one. Elderly, I never had a situation where people, that I would say like in this older 70s group, maybe even 80s group, like really needed any pain management with like eye stuff, especially injury or trauma. And dementia, of course, is another one. I'm going to skip a little bit because we are kind of getting out of time, huh?
Yeah, we're officially at the end of the CE.
All right, hold on. Where was this guy? I want to show you one. So about the ulcer, right? This is kind of just important. Just to touch on one point, I use pain as kind of like an indicator if I'm getting better or not. I rely on comfort more than I rely on cultures. Just be a past experience. We cultured everybody, everybody, because it was very convenient. I didn't have to do anything. I just got a culture, right? I got an army of residents ready to do it. And sometimes they'd grow stuff. Most of the time they didn't. And it was never really helpful, and even if it did grow something, the patient's already getting better, or I'm watching them. And then I think that I told you earlier before we started on is sensitivities, that was cool. I was able to see the sensitivities, but again, it was not that clinically vital. But for everybody listening, I think cultures are very, very important. Not from a clinical sense, but in a sense because people are going to ask you. Let's say something goes wrong with this patient. One of the first questions of the person that you're referring to is, did you culture them? And you're going to be able to say yeah, or you should be able to say yeah. It's kind of more like I think cultures are important if in the event someone asks you, because it's kind of expected, you know what I mean? Especially for ulcers greater than 1 millimeter. Whether they have a super important clinical role, I'm not going to comment too much on that. I think you can kind of get what I think. But for pain, really, it's the topical antibiotics, the steroids, the cycloplegia, the BCL, and the counseling, no narcotics. Can I just show you one last case?
Yeah, let's do it.
Do you guys want one last case, or we're done? This
Go
was a
for
case.
it.
This is something that happened to me. This is in Las Vegas, so I'm a private practice guy now, right? Doing premium lenses and stuff. But I do appreciate when the community sends me wonderful things that remind me of home and like my former work. I do have a very diverse practice now, and I see I take all kinds of crazy eyeballs. But this particular gentleman, slightly demented, very destitute. It was legally blind in both eyes due to non-compliant glaucoma. But when I first met him, he didn't look like that. He looked like this. So older dude, African-American, comes in, purulent discharge, both eyes. His complaint was, just goopy eyes, and his neighbors brought him in, because he doesn't drive himself, lived all alone. I'm like, okay, well, what do you guys think this is? Just off the bat. This is not him, by the way. This is a representative photo. You want to help me?
Say it looks like gonorrhea.
Exactly, right? And that's the first thing I said. I'm like, okay, well, I didn't have any IM ceftriaxone, so I wrote him a script for Doxy, and I put him on Moxie, and that's just been my, that's one of the things, the way I do it. And I told him preservative-free artificial tears as much as you can, right? And I said, come back and see me in a week. All right. He comes back without any drops. It comes back without any drops, and he'd already said he's got bilateral infiltrates. I'm like, crap. All right. So I'm like, okay, guys, I told his neighbor, I'm like, look, he didn't get his medicines, didn't do anything. We got to send him to the hospital. I'm like, okay, this guy obviously can't take care of himself, right? I'm like, okay, take him to UPMC, because they've got that's our local university hospital. They got social workers there. They've got people that can connect him with services. And they've got compounding pharmacies, and, I can talk to the ophthalmologist. 2 hours later, I get a phone call from another community hospital that was like, what the hell are we going to do with this guy? They had no clue how to treat, what to do. So I kind of talked him through it. He followed me as an outpatient for a while, and he was doing pretty good. He had his drops with him, because he got discharged with some stuff. And we ended up finding some distant family members, I guess like a cousin's kid that lived in Florida. They came out. They were going to take him to go live with them. We made follow-up appointments at an ophthalmologist. Life is grand. All right. 2 months later, he comes back to me, and he looks something like that. This is a representative photo. He had bilateral ulcerative corneal disease in both eyes. And I'm like, ah, crap. All right, guys, take him to UPMC, because I just wanted to stabilize him. He had hypopia and whatnot. Take him there. Let's stabilize this guy, and then I'll bring him back, and I'll give him some Gunderson flaps, because you don't need to take any maintenance. You don't need to do anything. So he goes to a different community hospital. Didn't go to UNC. I talked to the ophthalmologist on call. I was like, okay, just discharge the guy. Send him to me. I'll give him Gunderson flaps. Just hold him over the weekend. And the ophthalmologist on call really liked the plan. They discharged him from the hospital to rehab, and rehab refused to discharge him to me. So I was like, oh my God, all right. Well, anyhow, this is what he came back like, looked something like that. If you see, there's a couple little stitch marks. I saw him in the clinic. He looked something like that. I gave him a temporary tarsorrhaphy. Long story short, he ended up in the OR with us for the first ever enucleation at the ambulatory surgery center where I work at. So in this picture, there are those are optometry students that were on rotation. They got to watch. She got to scrub in, which means she got to stand a little bit closer to me so she can watch. So I ended up doing an enucleation and a Gunderson flap on the other eye. Well, one eye got the enucleation, the other eye got a Gunderson flap and a total tarsorrhaphy. But long story short, the patient's doing well. And question relevant to this talk is what type of pain medication was indicated in this patient? 0. He had no pain whatsoever. Dementia. I'm going to throw one last question. Is there any ophthalmic condition that would indicate long-term opiate use? There is one.
Oh.
Hospice care.
Oh.
Right? So I've seen 3 cases like this in my life where someone will have like an eyelid cancer. This particular one was basal cell carcinoma, where it just spreads and infiltrates the entire face and travels along the nerves, and it's very, very, very painful. There's no cure for this. This patient, after presentation, expired around 4 months, but during that whole time, he did require narcotics.
Well,
All right, I do
right?
have more, but I'm not going to go through it because I don't want to keep you. I hope you guys learned something.